Hello, everyone. Good evening. This is Dr. Ashkan Lashkari, MOASC president. Thank you so much for joining us today for our monthly lung cancer webinar series. Today we have a special discussion which will review the recent updates at this year's ASCO meeting that was held in Chicago earlier this month. And we'll have a really, we should have a nice discussion reviewing both early stage treatment of lung cancer and advanced treatment. And we're joined by two panelists, along with our moderator, Dr. Husain. We have Dr. Bazhenova from UCSD and Dr. Jonathan Goldman from UCLA, both medical oncologists specializing in thoracic oncology and lung cancer. Thank you so much, everyone, for joining. And Dr. Husain, thank you so much for moderating. I'll let you guys initiate the discussion. And then I just wanted to mention that today's webinar series is sponsored by AstraZeneca. So we appreciate their support. And then lastly, this is meant to be an interactive program, but there will be some short discussions in which some slides will be presented by the panelists. So if you have any pressing questions, put them through the chat box. We'll get to them, and then we'll open up to discussion thereafter. Thank you so much, Dr. Husain.
Thank you, Dr. Lashkari, and it's really a pleasure to be here and have both Dr. Bazhenova and Dr. Goldman here to discuss some of the pivotal abstracts that were presented at ASCO this last month. So without further ado, what we're going to do is Dr. Goldman is going to present some slides from the early stage sessions of the lung cancer track in ASCO. Dr. Bazhenova will present slides from abstracts in the metastatic setting. So Dr. Goldman, I'll let you now switch over to present your slides. After the slide presentation for each component, we'll have a discussion to reflect upon some of these abstracts.
Great. Thank you so much. This is really exciting. I think it was great to be back in fully in-person ASCO this year, and there's some really exciting updates in the lung cancer field. Two of them were in two of the biggest abstracts of the meeting were in the neo-adjuvant and adjuvant setting in lung cancer. So one of the plenaries was the Adaura trial, which I was able to participate in. It was an overall survival update from the previously reported disease-free survival benefit. And we saw that the DFS benefit translated to an OS benefit of 0.5, so very exciting. The Keynote 671 was another very important entry into the chemo IO combination and neoadjuvant with IO adjuvant, presented by Dr. Wakely in an oral presentation. And I'm just going to show you the top line results from the mesothelioma trial. Luda and I split it up kind of like the ASCO meeting with she'll be taking metastatic, and I did the perioperative and others, including mesothelioma. So I wanted everyone to be aware of that trial. So the Adaura trial presented by Dr. Herbst. We all know that lung cancer is unusual among the common cancers for high recurrence rates, even at early stage. EGFR mutations are among the more common driving mutations, particularly in Asia, but also a very significant component of our patients in the United States, and especially in Southern California. There have been several trials over the previous decade looking at adjuvant use of targeted EGFR TKIs. They have, prior to Adaura, showed some suggestion of benefit, but not a meaningful OS benefit, not a significant OS benefit. This is the DFS benefit showing the 0.2 overall in stage 2 and 3, 0.2 hazard ratio for disease-free survival. So really quite a dramatic benefit that led FDA to approve osimertinib in this setting and for it to become practice-changing for many oncologists. The trial was randomized against placebo, 680 subjects. Treatment was for 3 years. From 1B to 3A were allowed, and the primary endpoint was stage 2 and 3A. So this was the DFS benefit initially reported on the left and then updated earlier this year. Really significant. I think it's interesting to see that beyond 3 years of therapy, the curves do come somewhat back together, but they do remain separate. And so it was important to see how this would translate to OS. The two groups are well matched. And the overall survival with a hazard ratio of 0.49, I think really certainly outperformed my expectations. Those curves separate, and for the length of time, the maturity was about 5 years. These curves do not seem to be coming back together. Of course, they may over further follow-up, but I think this separation for this length of time is really clinically quite meaningful to our patients, and a hazard ratio of 0.49 is very significant. And I do like to think about the comparison to other breast cancer trials, for example, where a much smaller numerical difference really creates practice-changing waves. And here I think we've had in lung cancer the most important adjuvant finding that we've had in a long time. The forest plot does hold together quite nicely. Exon 19 deletions did a little bit better than L858R. Non-Asians did better than Asians. Who knows what to make of that? But otherwise, generally pretty good adherence, and in all groups do seem to be benefiting. The stage 1B and 2s, these confidence intervals do cross 1, but the trial was not powered for that, and clearly the point estimate is well to the left of unity. So I take this to mean even in the stage 1Bs, there is a overall survival benefit here that's meaningful. The absolute difference, of course, is smaller in the 1Bs, but the hazard ratio is very similar across stage. Here's the Kaplan-Meier curves. I was going to start my timer, make sure I don't go over, to give time for discussion. But I think that each of these curves does support the use here. This is, I'd say, the one place of controversy, and certainly would look to have discussion about this further, but 40% of patients after progression got on osimertinib. And I think actually historically that compares pretty well to other trials, but scientifically there is the question of the trial: is it better to give osimertinib right after surgery or wait until recurrence? If not everyone on recurrence got osimertinib, we don't answer that question as purely as possible, but I still think that most of the patients got an EGFR TKI, which while perhaps not quite as good as osimertinib, is also a good therapy. And to me, this criticism doesn't take away from the meaningfulness of the results. And I guess I challenge even the people who make a big deal of this. Does this mean they wouldn't use osimertinib? I think that's a hard argument to make. No new safety signals were found in the trial. For the sake of time, I'll move quickly. So the hazard ratio for overall survival of 0.49 is the take-home point here. There's some ongoing interesting trials, which many of you are participating in or aware of the Neo-Adaura trial, looking at neoadjuvant, OC, or chemo, or both. The Adaura 2 trial, which I'm running in North America, is looking at the 1A2 and 1A3, so tumors that are 1 to 3 centimeters. Did very well accruing in Asia and in Europe, actually, but still some work to be done in the United States. So if you're running the trial or want to refer for the trial, please keep it in mind. And then the target trial is trying to evaluate whether more than 3 years of therapy may be helpful for some stages of patients. And that trial has not begun accrual. So next I wanted to go to Keynote 671 presented by Dr. Wakely. Also, I'd say practice informing, and I'm very interested in further discussion. 786 patients randomized 1-to-1 to get chemo with placebo or chemo with pembrolizumab, neoadjuvantly for up to 4 cycles, and then adjuvantly for a year. The arms are well matched by stage and PD-L1 status. The histology is also well matched, majority non-squamous, but a little over 40% squamous. Just want to see if there's anything else I wanted to highlight here. About a third stage 2, half stage 3A, and a minority stage 3B. The majority of patients were able to get to surgery. There is no suggestion that pembrolizumab worsened the surgical outcomes. There was a higher percentage of R0 resections, a very similar percentage of pneumonectomies, and there were a few deaths in the pembro arm, a few more in the pembro arm than the placebo arm, amounting to a difference of 1.2%. But the event-free survival are really similar to the checkmate, really a very significant hazard ratio improvement for event-free survival in the pembro arm. As you can see, the curves separate and remain separated quite well. Forest plot, again, hangs together nicely. There is perhaps a trend of meaningful, greater benefit in PD-L1 high, but even the PD-L1 absent do have a good point estimate of benefit. Some of the things I think are worth discussing that distinguish this trial from the checkmate trial are that they included some EGFR and ALK patients, not a high number, but it is interesting, the EGFR mutated patients, only 1 recurred in the pembro arm, but 10 recurred in the placebo arm. So I guess we can discuss what to make of that. And of course, this therapy would be contraindicated in someone getting osimertinib. So you can't do both Adaura and pembrolizumab. The overall survival, it's immature, but looks promising. It's just based on the statistical design that this p-value doesn't cross the threshold for statistical significance, but very encouraging. The reporting was similar to checkmate. The path CR rate was improved meaningfully, 3 to actually a little more than 4 times higher path CR rate in the pembro arm. The pembro arm does do better than placebo, whether or not you get a path CR, which was interesting to see. They also looked at, path CR, they also looked at a major pathologic response, and these outcomes look similar to the path CR rates. The adverse events, the pembro therapy was generally quite well tolerated. As would be expected, there was more immune-mediated adverse events in the pembro arm. But interesting to see 10% immune-mediated adverse events in the placebo arm, just showing how it can be quite difficult to determine etiology of some adverse events. I think, I thought this really highlighted quite nicely how well drug was tolerated. The adverse events and by grade really look quite symmetric in the two arms. These are the immune-mediated ones, hypothyroidism as expected being the most common, and the more serious ones were really quite rare. So I think this is a very interesting trial, interesting to compare to Checkmate. I have a slide on that in a second. But the path CR rates were very encouraging, as was the event-free survival. I think you have to look at that overall survival curve and think that they will be reaching an overall survival statistical benefit there as well. So Checkmate 816, just to remind you, had 3 cycles of neoadjuvant chemo-nivo and event-free survival of 0.63, hazard ratio for event-free survival of 0.63. There was a you can distinguish the hazard ratio based on the PD-L1 expression levels. The path CR rate quite a bit higher in the nivo arm, 24 versus 2.2. So if we compare these two trials, which I think are, to my mind, perhaps the most practice informing, and adding in GN, which looked at durvalumab with chemo and in maintenance. Perhaps the main thing is that the trials look pretty similar, made significant improvements in path CR, and the hazard ratios look quite good. Interesting to also think about the Neo-TORCH trial, which has terripilimab in the Chinese study. But I think we've clearly confirmed for these patients that giving chemo with neoadjuvant immunotherapy with chemo is a meaningful, quite meaningful improvement for our patients. And I've heard different thoughts about this. I think the main thing that I think about is, do you want to give adjuvant immunotherapy after you've given the 3 cycles or 3 or 4 cycles neoadjuvantly? I don't think that this data strongly supports that you need to give that adjuvant year of immunotherapy. There's certainly the cost to the system that you might avoid. I don't know that there's a huge impact in toxicity, but time in the office, etc. I don't think that these numbers clearly support that, but I look forward to the discussion. And as I said, just the top line results from this trial, I'll remind you that a trial reported a couple of years ago in Lancet showed that Nivo-Ipi outperformed platinum pemetrexed in mesothelioma. This was pembrolizumab with carbo-pem, or cis-pem, excuse me. Most of the patients got cis-pem. Sorry if I misspoke. It's cis-pem with pembro versus cis-pem. And the pembro arm did better than the chemo alone arm. This is a curve separated out by histology, epithelioid. The immunotherapy adds a little bit of benefit, and in the non-epithelioid, a lot of benefit. And this is from a Lancet trial, Nivo-Ipi, and these curves look pretty similar. So I think we have 2 good immunotherapy arms, one with chemo and one with Ipi. The Ipi does add a fair amount of toxicity, so the authors argue that this chemo pembro arm should be considered as a new meaningful option. Those are all my slides, and I look forward to the discussion. Thanks very much.
Thank you, Jonathan. That was really a great summary, and really gave us a lot of perspective on the early stage space. We do have a few questions that have come in the chat, and I also have just some questions that came to mind as you were presenting. Maybe we'll start actually with the Adaura study, and there are some questions that have come in. One question from the audience is, what would you do in a patient who's had completely resected stage 2 non-small cell lung cancer with EGFR S768I mutation? The atypicals, how would you comment based on Adaura or kind of, philosophy thereof, in this space, and Dr. Bazhenova as well, please, your input as well would be great here. But Dr. Goldman, your view.
Sure. So I think it's a good question. I think that the different atypical mutations act very differently, and I look most of them up just to make sure, because some of them are similar but do act differently. The S781I, I think, is the one that you said, does behave pretty similarly to L858R. So I would off-label use osimertinib in that situation, whereas an exon 18 or an exon 20 mutation, which don't get nearly the benefit in the metastatic setting, I would presume that the benefit would not be seen. You could imagine pushing me on a tough one, a very high stage 3A with G719 maybe, which doesn't do quite as well with osimertinib. But I guess I could bend on some extremes like that. But in general, I would treat the point mutations.
Dr. Bazhenova, your view?
So I had a little bit of a leg up over Jonathan, because I saw the question as he was talking, and I completely agree with you, Jonathan, that I have to look it up. I can't remember which mutation we have, so I was able to look it up. So 761I is actually a PAC mutation, so it's not an EGFR classic like behaving. So it's a PAC mutation. And I actually had a patient like that. I actually tweeted it because I, had difficulties on, making decisions. So I saw a patient with G719A, which is also an atypical mutation. So the challenge here that those patients would have been excluded from Adaura. So we don't have any prospective data. The second challenge is that since this is a PAC mutation, which is according to the new classification that's come from MD Anderson, the PAC mutation are more sensitive to afatinib than it is to osimertinib. But we don't even know if afatinib is tolerable for 3 years. It's not a drug that's easy to give. And so I asked my colleagues, I did like mini tumor board saying like, what would you do? And it's interesting, 50% says they'll just observe because it wasn't included in the study, so we don't know. Allowed 11% recommended afatinib for, lack of any data. And about the rest will say give osimertinib. And the rationale for giving osimertinib is it's probably going to be better than placebo. At least we have the data for long-term safety. But honestly, there is no right answer. So I think right now, I probably would do the same thing as Jonathan. I probably would offer osimertinib, but just because I'm having hard time envisioning 3 years of afatinib. And, you can't even do full dose of afatinib majority of the time. And so it would be nice to have an adjuvant study for all those PAC mutations, but we don't have it.
I think great perspectives. And I think, some other kind of elements of the Adaura that I think are important to discuss here are effects in the brain. How does afatinib compare to osimertinib in terms of CNS response? And then the other kind of interesting point here is that, again, Adaura allowed chemotherapy or, patients to receive adjuvant osimertinib without chemotherapy. So, the only thing I would kind of add here and contribute is that in a patient with an atypical mutation, this is probably a patient that should be getting chemo and then osimertinib because of the historical lower rates of response with some atypical mutations. But again, that's a debated point. It would be great to see a trial like Adaura inclusive of the atypical mutations.
Yeah,
I had a question.
Yeah.
Along the lines of in the Adaura trial, whether or not, based on the results now that we have, the overall survival results that we have, would you offer, let's say somebody has a conventional EGFR mutation, an exon 19 or L858R, would you, if they were, would you offer chemotherapy to these patients or would you not? Is that something that we should be doing on top of chemotherapy, a bit on top of the osimertinib, based on this trial suggesting that maybe there isn't a significant benefit from chemotherapy here?
So I think
on
that's an
this,
excellent question. Yeah.
Yeah.
And actually just wanted to say, actually, that was going to be my next question, but also, just to frame the question first for Adaura, chemotherapy was permitted. And that, I mean, meaning chemotherapy was allowed and patients could get osimertinib with or without the chemo. In the ASCO presentation, there was details presented. And so I'll let Dr. Goldman kind of talk about the role of chemo there. Mhm.
so yeah, I did include all the slides, and some of them were the group who got chemo and the group that didn't get chemo. Both did get a benefit. And in fact, the hazard ratio, my memory is the hazard ratio is a little better for the patients that got chemo. And I'll explain why in a second. The trial, didn't randomize patients to chemo or no chemo, so I don't think the trial can inform our chemo decisions. So what I do is I actually separate out in my mind the chemo decision and the osimertinib decision. And so if they meet my old criteria for chemo, which is over 4 centimeters or lymph node positive, I give chemotherapy. And then following that, then if it's over 3 centimeters, basically, and certainly if it's L858R or exon 19, I give osimertinib. I think that the part of what happened on the trial, as you would expect thinking about it, is that the 1Bs, a lot of them did not get chemo, but the 3s, almost all of them did get chemo. And so that's why when you look at who got the most benefit from OC, it's the people that got chemo, because that was also the higher stage. But I think that the care was appropriate. I do think, the people that are 3 to 4 centimeter tumors and EGFR mutated, I'm very happy now to say we're not going to give chemo, but we have another approach that's very effective. The 4 to 5 centimeter tumors, I'm still kind of on the fence with, and I discuss with the patients. And an older patient, I might skip chemo and give OC only, but a younger, more aggressive patient, I will still give chemo and then follow it with OC.
And I think, Hatim, the reason why neither Jonathan nor myself started discussing that case with chemo is because we are convinced that chemo is necessary. So our question is not about chemo, it's about what type of chemotherapy. And I think kind of I fully agree with you when you said that chemo is necessary here, just because we should be very vocal and very understanding that chemo has been proven to improve cures in those patients. And unless I have the study that chemotherapy is not necessary for the EGFR mutant patients after resection, we should give chemotherapy.
I think that's an excellent point. And I will say in my practice, this comes up a lot. And I will say there are patients who just do not want to receive chemo at all. And I think one of the silver linings of Adaura is it still permitted people to have a pathway forward. But I agree with you that, chemotherapy is a standard and, really, has had an established role in this space. And so I think really thinking that through. And I think, just the one point around with the atypicals, perhaps having a lower response rate with osimertinib by themselves. Well, great. No, I think this was fantastic. I do want to have a few questions about Keynote 671. And so in that regard, some of the questions that came to my mind, Jonathan, as you were presenting, were the backbone for the chemo for Keynote 671 was a bit different for the squamous. Do you view how does that influence your decision to think through a neoadjuvant strategy? I mean, gemcitabine is an option, there's paclitaxel. Is that important to you at all?
So I think my memory is that the non-squamous got cis-pem and the squamous got cis-gem. That's my memory of the trial.
Yeah, I believe the squamous probably, got the cis-gem and then the non-squamous cis-pem.
I'm so sorry.
Yeah, no, it's okay. Yeah, it's a long day for all of us. I know Dr. Bazhenova and myself at clinic today too. So.
So in the adjuvant setting, with some exceptions, if I'm going to give cisplatin, I don't love to give a taxane because I think that the neuropathy can be really problematic and lifelong for hopefully someone that's going to live a long time. So I think the cisgem was appropriate. In California, at least I certainly see very few squamous cell patients, so this doesn't come up that much. But when it does, I think cisgem is a very appropriate therapy. So I don't think the chemo choice affects my decision between following a Nivo or a Pembro-based arm. One thing that is interesting is I have used, based on Checkmate, the carbo-Taxol regimen quite a bit more than I ever did before, and that wasn't part of the Keynote trial. So that is an interesting area for older patients or for non-squamous. For squamous, excuse me, I'm often doing carbo-Taxol now.
No, that's super interesting. And one question for you both is, so Checkmate 816 allowed both cis-based regimens as well as carbo with Taxol. In your patients who you give neoadjuvant, do you unanimously use cis? Are there patients that use carbo in that setting?
Luda, do you want to answer that? You're on mute.
Unmuted. So I tend to stay with cis unless I have an absolute contraindication for cis. My overall thinking has been, if I'm going for cure, I do want to use cisplatin-based therapy.
Thanks. Yeah. One other last question that I have before we turn over to metastatic is, so in my clinic, I have a patient who got Checkmate 816 after surgery, had 40% necrosis, but 60% viable cancer, after the 3 doses of treatment, 3 cycles of treatment. So this patient has asked me, now that I've completed this, what do you think? So I said, I would go to ASCO and try to provide them an answer at the end. Now I'm going to turn to you both. Actually, in this circumstance, where a patient has residual disease post neoadjuvant chemo IO, would you give a patient perioperative IO now after hearing Keynote 671? Is that something that you would advocate for? Or do you think actually that, and how do you think through major pathological response or complete pathological response, the pathological response in terms of guiding your decision for patients?
I'll just say really quickly, I think this is very difficult. I think you give 3 cycles of therapy, either it worked great, and then you think, well, why do I need to give more? Or it didn't work great, and then I think to myself, why should I give more? It didn't do what I needed it to do. And so I honestly find this challenging. I did not, as I said, I didn't think that the hazard ratio for disease-free, event-free survival was a little bit better in the Keynote trial with neoadjuvant and adjuvant, but the difference in the path CR rate was a little bit worse in that trial. And I think the trials just look really similar and don't clearly demonstrate that adding that year of IO at the end is helping our patients. It would be great to have a randomized trial where everyone got neoadjuvant chemo IO and half the patients got adjuvant IO. And my understanding is that some of the cooperative groups are planning that, but I don't think it's underway as of yet. But until we have a trial head to head, I think it's really hard to have a clear answer. And for myself, I think I'm going to stick with Checkmate 816 for my patient.
And Dr. Bazhenova, yourself here, actually, what would you do in this circumstance?
I have pretty much identical thoughts to Jonathan. We don't know, and if you look at the cross-trial comparison, I don't know how much adjuvant immunotherapy helps for exactly the same reason. Like, if it already killed things, why do I want to do extra? If it didn't kill things, why do I want to do extra? Because it didn't really work in the first place. So I waited for the studies.
No, thank you both, actually. I think this is really good discussion on the early stage and obviously a lot of unanswered questions. So now we'll transition, and Dr. Bazhenova, if you don't mind sharing your screen with the slides for the metastatic, that would be great.
Yeah, so I'm going to cover metastatic disease. So there is not much practice changing in this setting, but there are a couple of compounds which I think has the potential to change our practice once the more updated trials are going to be completed. So I'm just going to go through kind of what is going to happen in the future in metastatic disease. So the first abstract I want to highlight is Keynote 789 study, which is platinum doublet with or without pembrolizumab for EGFR mutant secondary resistant patients. And so the way I structured my talk is I want to first say, okay, what did we know before the study started, and why are we asking that question, and then go specifically to the data. So what do we know before the study was run is the only combination immunotherapy that is approved for patient with post-tyrosine kinase inhibitor therapy is Empower 150. And Empower 150, as all of you know, is a quadruplet. There was 3-arm study, was quadruplet versus chemo IO, then quadruplet versus bevacizumab chemotherapy. And patients with EGFR and ALK mutations were allowed in the study, assuming they have failed TKI. And as you can see here, that the quadruplet did show a superior outcome versus bevacizumab chemo platinum. But I think at this point, what we don't know is once we go into Empower 150, we have to stop tyrosine kinase inhibitors. And eventually what's going to happen to those patients is that they're going to progress in the CNS. And now you've given them immunotherapy. You can't easily go back to the tyrosine kinase inhibitors because of the sequencing pneumonitis. So the question that the 789 asks is specifically prospective study designed to answer the question of, do you need immunotherapy in a patient who have progressed after EGFR TKI? The study design was the patients were failing either first or second generation EGFR TKI, as well as third generation EGFR TKI, and then they were randomized to platinum doublet plus pembrolizumab versus platinum doublet. And the primary endpoint was progression-free survival. Dual primary was progression-free survival by both by blinded independent committee review as well as overall survival. So the left bottom part of the slide, you can see that the forest plot saying that none of really patients really did not see improvement in additional pembrolizumab. So the question that I get very commonly, what if my patient has a very high PD-L1? And you can see at the bottom of the forest plot that really didn't matter if you have high PD-L1 expression or no PD-L1 expression. There was no additional benefit from adding pembrolizumab to chemotherapy after your patients failed EGFR tyrosine kinase inhibitors. On the right part of the slide, I showed you progression-free survival and overall survival. And even though the p-value is less than 0.05, 0.01 and 0.03 to be exact, the way the statistical analysis was done, this number is not statistically significant. And if you look at the median numbers, the median PFS was 5.6 months in immunotherapy arm, 5.5 months in non-immunotherapy arm, and overall survival 15.9 versus 14.7. So what did we learn from the trial? And I think this is the only, not really practice changing for me because I was never using immunotherapy. Recently wasn't using immunotherapy post EGFR TKI, but practice confirming in my opinion. So currently, I will not use immunotherapy plus chemotherapy in patients who progressed on EGFR TKI because we now have 2 negative trials. One is the one that I just presented, Keynote 789, and then there's another trial that was presented in December of 2022 at ESMO Asia by Tony Mock. Very similar study design, Checkmate 733, also showed no improvement in outcomes if you add immunotherapy for patients who failed EGFR tyrosine kinase inhibitors. So the next abstract I'm going to highlight is a new kid on the block called sunvozertinib, not yet approved by FDA. We know that this drug is DZD9008, and this is a new tyrosine kinase inhibitor that's specifically designed to inhibit patients with EGFR exon 20 insertion. So our current state of practice is that in the patient with EGFR exon 20 insertions, we have mobocertinib, which is a tyrosine kinase inhibitor, as well as amivantamab, approved in second line. And if you look at the overall response rate was 28% in mobocertinib, 40% with amivantamab. Very important to pay attention to the major toxicities. You can see 91% of the patients have diarrhea with MOBA, 21% grade 3 plus, and then a significant amount of rash. There is also an infusion reaction. So even though we are welcoming a new drug for patients with EGFR exon 20 insertions, we are looking at drugs which have better efficacy, potentially hoping to find the drugs that have better efficacy and lower toxicity. And just kind of this is, I highlighted to you toxicity of the mobocertinib, as I mentioned before, diarrhea 91%, and then grade 3 diarrhea 21%. And so sunvozertinib was patients with EGFR exon 20 insertions. They have to have failed platinum doublet. So this is a second line trial. And everybody was a single arm phase 2. Everybody got sunvozertinib. And you can see here that the partial response was 60%. Remember, for mobocertinib, the partial response was 28%. This is a smaller study, so you have to take those numbers with a little bit of a grain of salt, and certainly we could potentially see the overall response rate going down as we enroll more patients. But I think what I'm most excited about this compound is the rates of diarrhea. So remember, for MOBA, 91% all grade, 21% grade 3. And here you see 67% of all grade is only 7.7% of grade 3 toxicity. And also the rash is a little bit less frequent than I would see with mobocertinib. What also was exciting for me, this is a different abstract, same drug, very small number of patients. You can see only 28, but efficacy of sunvozertinib in patients with EGFR exon 20 insertions who were treatment naive. So platinum doublet naive, treatment naive, newly diagnosed. And here you see that the overall response rate is 71.4%, which I think is very respectable. And the company is running the study right now, which will allow treatment naive patients as well as second line TKI naive patients. And we do have that study open at UCSD if any of you are interested referring. The next abstract I'm going to highlight is something that could potentially change our practice down the line. So remember, for the patients who have a newly diagnosed lung cancer who are oncogenically driver negative, the current standard of care involves immunotherapy. You can either use chemotherapy plus immunotherapy, or you can use immunotherapy by itself, depending on your preference and depending on PD-L1 expression. And we know that based at least on Keynote 189, definitely chemoimmunotherapy works. And we see a significant improvement in 5-year overall survival compared to platinum doublet. We also know that in thoracic oncology, we now see an explosion of antibody drug conjugates. We only have one approved currently for HER2 exon 20 insertions, but we have several in development. And the drug here that I'm highlighting is Dato-DXd, or datopotamab deruxtecan. The name of the trial is TROPION-Lung02. And basically what we are trying to do is trying to replace carboplatin with antibody drug conjugate. This is a very early clinical trials. You can see the number of patients are very small. But if you look at first-line mean treatment-naive patients, overall response rate for a triplet combination, which is chemotherapy plus Dato-DXd plus immunotherapy, is about 57%. We do not yet have any progression-free survival data. There are ongoing studies which will compare platinum doublet IO versus data pemetrexate IO. So this is something to look out for in the future. So next, I'm going to switch gears and go into the KRAS G12C patients. So knowledge before the study is we have 30% of our patients who have a KRAS mutations. Half of them, or 15%, will have a KRAS G12C mutation. We currently have 2 drugs approved in the second line. And as you can see here, I put kind of a summary of those 2 drugs. The overall response rate is around 40%. Median progression-free survival is 6.5, about slightly over than 6 months. Median overall survival for both of those drugs is slightly over 12 months. So it's good, but certainly we are looking for ways to improve outcomes of patients with KRAS G12C mutation. And there is a new compound, JDQ443. The reason why people are investigating this compound is it has a better bioavailability. So we are hoping to be able to deliver more drugs to the patients. And again, this is a small study, but you can see that confirmed overall response rate at the recommended phase 2 dose, which is going to be 200 BID, is 57%. So maybe a little bit higher than what we saw with adagrasib, sotorasib. Again, drug is not approved, but currently this is something that I am at least personally looking out for. And toxicity profile for this medication is very compatible to what we see with adagrasib and sotorasib. Maybe a little bit less diarrhea compared with what we see with the competitor drugs, but certainly, definitely needs to be investigated further. So the other question we need to answer in patients with G12C mutation is, what if we're going to use targeted therapy in first line? I think none of us are excited about using monotherapy targeted therapy in first line because I don't think the efficacy is going to be strong enough. So people are trying to see if we can combine chemotherapy plus sotorasib. I am not advocating it for now because we need a larger trial size than what we have right now, and we basically need a randomized trial comparing platinum doublet versus this combination of chemotherapy plus sotorasib. But I'm very excited to see response rates. If you can see here on the right side of the slide, the overall response rate is 88.9%. So in my opinion, this is definitely where we should be going as a part of a clinical trial in patients with KRAS G12C mutations. So the next kid on the block is repotrectinib. So repotrectinib is a second generation ROS inhibitor, which has activity against ROS1 resistant mutations and have a fairly decent CNS penetration. So as you know, ROS1 rearrangements are seen in approximately 1 to 2% of patients with lung cancer. This is the current landscape of ROS1 inhibitors. The two drugs that have an FDA-approved indication is highlighted here in the green box, and those are crizotinib and entrectinib. And just so you kind of have an idea of what we would expect for those drugs, the overall response rate in the order of high 60, low 70s, and progression-free survival is around 18 months. And so there were presented new data of repotrectinib, which is again another tyrosine kinase inhibitors for ROS1 fusion. And you can see here that the overall response rate, a small number of patients, but nevertheless is maybe a little bit higher than what we see with entrectinib and crizotinib. Again, needs to be confirmed in the larger population. And at this point, we don't have the PFS data reported yet. We only have a PFS rates. And at 12 months, around 80 to 70% of the patients were still progression-free. I think what I'm most excited about the drug is fairly good CNS activity. This is intracranial efficacy of repotrectinib in patients with measurable CNS metastasis. And you can see that intracranial response rate is 88 and 42%, which is pretty significant. So currently UCSD does have that study open, and ROS cohort at this point is closed. So we only have an NTRK. So repotrectinib is actually like entrectinib. It's both ROS1 as well as NTRK1 drug. So the NTRK cohort is still open. The ROS1 cohort is closed. And so to finish, I have one more slide. This is another compound I'm watching out for, is a Blue 945. This is a compound that is being developed for patients who develop resistance to osimertinib. So as you know, osimertinib is currently approved in patients with newly diagnosed EGFR mutant lung cancer based on a FLORA study which compared osimertinib versus standard of care tyrosine kinase inhibitors and showed improvement in progression-free survival compared to first generation EGFR TKI. Great drug, but unfortunately doesn't work forever. And at about 19 months, we're actually starting to see resistance. Once you look at the resistance pattern, you see that the most common mechanism of resistance is MET amplification or mutation, but there is also what's called an on-target resistance when you develop mutation or acquired mutation in EGFR domain. And one of the most common mutations that we see in EGFR domain is so-called C797S, which interferes with binding of osimertinib to the EGFR receptor, and that's why this resistance is being developed. And we have several drugs right now being looked at specifically for patients with C797S, as well as the patients who develop resistance to osimertinib. And this is one of those compounds, as Blue 945, that was presented as an oral abstract by Element. And this was a phase 1 dose escalation versus expansion. There was 2 arms here, Blue 945 monotherapy versus Blue 945 osimertinib. As you can see, based on the forest plot, even though they have not formally reported overall response rate, you can see that really you don't see a significant number of patients responding to at least Blue 945 monotherapy. But I think what's interesting in that presentation, if you look at the bottom waterfall plot, you see where I highlighted EGFR C797S mutation. So you can see that majority of the responders who responded to Blue 945 and osimertinib actually did have a C797S mutation. So maybe this is something that we're going to be doing in the future. The study is still ongoing. They're very early in development. So right now it's too early to say if they're going to have an approval or not. And that's my last slide, and that will conclude my presentation.
Thank you, Lida. That was actually such a fabulous whirlwind of all of the metastatic abstracts and really kind of thought-provoking in some ways. I may just kind of start with some questions about this, certain things that, I've been thinking about and for questions about in some ways is, so if we start with Keynote 789 in this space, for EGFR patients, are there any patients who should be getting an IO agent? How do you think through, are there any patients in your practice who get IO of EGFR?
No, I don't. So my, again, not supported by any data, but I'm a believer in continuation of osimertinib. Just because what I've seen so far is, especially in patients who have brain metastasis. So once you stop osimertinib to go on chemotherapy, they eventually progress in the brain. So I know the IMPRESS-2 study is still ongoing. We don't have the results, but I tend to continue osimertinib if I can. If I cannot continue osimertinib, I stop osimertinib, give chemotherapy for 4 or 6 cycles, and then put them back on osimertinib. And you get, another maybe 6 months out of it. So right now, outside of the clinical trial, I'm not giving immunotherapy to patients with EGFR mutations who develop resistance to osimertinib.
Along those lines, can I add a quick question, Dr. Bazhenova? I have a patient right now who's got an exon 19 EGFR mutation, presented with metastatic disease to the brain, small lesions, did well with osimertinib, and then developed progression in the brain. In that situation, would you still continue osimertinib? I'm assessing if there are any resistance mutations, but considering starting them on chemotherapy and continuing the osimertinib.
Yeah, I probably, so assuming we're gonna radiate the brain, because since they progressed on osimertinib, I think I probably would lean towards radiation. There is no right answer to your question. So I think once they have brain metastasis they're more likely to have another brain metastasis. So I would lean towards continuing osimertinib. But chemotherapy is a good option here because, as we know, pemetrexed does have CNS penetrability and a little bit of carboplatinum as well. So I do exactly like what you did. I would continue OC at carbapeme, but before that, I would actually do the brain radiation.
Thank you. Sorry.
Really good points. And I will say also that I'm sorry to kind of interrupt you. We always kind of do that, but no, I was going to say actually that I really appreciated your points about CNS protection, in the brain, continuation of OC. Jonathan, in your practice, are there patients that you give IO agents to who are EGFR mutant?
I mean, certainly all of Luda's points are very important, and I think a lot of data behind them. But there are patients that I give Empower 152. Sometimes I'll keep it for a kind of a second platinum doublet regimen, on the third or fourth line. But I think there are some nice things about that regimen. I like that there's a period of chemo and then they go into a non-chemo maintenance. The response rate in the EGFR mutants is not zero, and it's probably maybe 10% or maybe 5 to 10%. But we do know that the benefits to immunotherapy can be very long lasting, and the idea that someone with lung cancer might never get immunotherapy isn't great. And so that I figure the best way to get immunotherapy for these patients is while they're getting chemo. That said, a lot of times, if someone has active brain mets that were never radiated, I also do like to keep osimertinib going, and then I give it with carbopen. And I think these CNS only progressions are among our most difficult patients these days. One thing I do sometimes try is double dose osimertinib following the Bloom trial. The benefits are not super common and not super long, but I often will give that a try along the way as well.
I think, Jonathan, I do agree with you in a way. If I'm gonna ever consider immunotherapy for those patients, I will consider it as a quadruplet. I would consider it as per 150, which is beva, carbapenem, atezza. Just triplet, I usually don't.
I agree with that. We are going to be opening up in the next few months the ivonescimab trial. This is the bispecific to PD-L1 and VEGF in combination with carbopen versus carbopen alone. It'll be interesting to address this trial in an EGFR mutant only population, and in my mind that will carry the day. If there's no benefit in that trial, I'll stop doing Empower.
Really good points. Just in the last few minutes we have, I did want to tackle the data for datopotamab deruxtecan. Lotta, thank you for that very fantastic review. You started the slide actually showing the long-term tail of the curve with Keynote 189. How do you see datopotamab integrating into lines of therapy? Which lines do you see it entering into the first line?
Not initially. I think initially, based on the data we have, and I think Jonathan is a little bit more involved with the compound than I am, is going to be a second line approval if it's going to, fit the FDA criteria. But I think it's reasonable to try it in the first line, and maybe it's going to be able to replace the platinum in first line, but it's not going to go there right away.
Do you see points of distinction? You mentioned the triplet combination, and datopotamab would be replacing pemetrexed. How do you see kind of the pros and the cons?
I think it's replacing carboplatin.
I think it's going to replace carboplatin, yeah, not pemetrexed.
Okay.
In the future studies. That's what I'm.
In the future studies,
yeah.
But in the current study that was presented.
In the current study, it's replaced the pemetrexed.
The pemetrexed. So in the current study with pemetrexed, so this is actually a very interesting point, actually. So in the current study, it replaced pemetrexed, and what you're saying is in the future studies, it'll replace carboplatin.
That's my understanding. I don't know if you're aware of the future, the triple.
No, that's I actually hadn't focused on this question. It is very interesting. Sacituzumab also has a similar trial where they're trying to get another TROP2 ADC into the first line chemo IO, and they are also trying to replace the platinum. And it's interesting, what would we rather get rid of? But there is an advantage, I think, to a non-platinum regimen. And I guess you could always go to a platinum in the future.
No, I think it's super interesting, especially in light of the current platinum shortage, just how dependent we are on one agent platinum. But I will say this is that, just with the current data that we have replacing pemetrexed, do you view points of distinction with Dato-DXd compared to pemetrexed? And how does that distinguishing point factor for you?
I think you can distinguish, how do we distinguish drugs? So we distinguish it based on efficacy, and then we distinguish it based on toxicity. I think it's very possible, in my opinion, that Data-DXd could distinguish itself from pemetrexed or carba based on efficacy, but I am worried a little bit about toxicity, because carbapemetrexed is a very easy to do chemotherapy. And we know, at least I personally don't have an experience with Data-DXd. I don't have the study open, but my experience with other antibody drug conjugates is that they are not simple drugs. They have long-term toxicities, ILD and keratitis, and sometimes mucositis. And so I think it remains to be seen if potential improvement in efficacy will be stricken out by worsening in toxicity. And that's, I think, we need to wait and see.
Good points. Well, no, thank you, actually. And just want to open it up for any last questions here, or any other last comments, actually, from our panelists as well. Points of things that seemed interesting. I mean, so many kind of curious points about, novel agents, and thank you for, Dr. Bazhenova, for kind of introducing some novel agents in the exon 20 EGFR space, as well as, really kind of redefining, additional agents, perhaps kind of in the ROS1. I think that the sotorasib plus chemo also kind of was very high response rate. Those were interesting abstracts to reflect on. So maybe actually, if there are no other further questions, I'll turn it over to Dr. Laskari for wrapping up the meeting, and thank you as well for all your participation.
This was wonderful. This was wonderful. Thank you so much, Dr. Husain. Thank you. Special thanks to Dr. Goldman and Dr. Bazhenova for putting together this amazing review. And I certainly learned a great deal, and I'm sure the rest of our audience has as well. Thank you, everyone, for joining us as well. So that'll conclude. Again, thank you to our sponsor, AstraZeneca. Next month, we'll be coming back here in about 4 weeks, and we'll be talking about first-line IO therapy in the metastatic setting. So we'll have more to talk about then. And obviously, we talked about it a little bit today. So we'll get into the weeds next month. Thank you so much, everyone.
Thank you.
Thank you.
Bye-bye.
Thank you very much.